And tonight we have another one of those professionals. Tonight we have Emma Finan, who has been a friend to this program for many, many years. Our caregivers especially have known her as she used to come into our classes and share on boundary setting and self-care and empathy. And tonight she's got a topic that I think is touching a lot of chords, or we wouldn't have the signups that we have. And tonight she will be checking in with you and sharing with you on grief and mental illness. And so, Emma, I'm going to let you do it somewhat of an unmute yourself and do somewhat of a introduction for yourself, because you can tell best about that, and then an intro to what you're doing, and we'll get started. We're delighted to have you.
Oh, thank you. Well, first of all, yes, thanks for the invitation, the NAMI invitation. It's always nice to be able to share, my experience and knowledge with the NAMI family. And I am a therapist in the first episode psychosis clinic at Vanderbilt. I've been there in that particular clinic, about, I think, maybe 12 years now. And I have the privilege of working both inpatient, and then I'll meet some of the my patients inpatient and then follow them in the outpatient setting. And as you probably know, there's a big team of us, lots, doctors, psychologists, therapists. We've got a SEAS worker. We had peer support specialists. So there's a large team of us that provide that kind of work at Vanderbilt. And Tracy had mentioned there her 25th year, and that's actually my I'm 25 years at Vanderbilt too. I've worked in a variety of different settings, so that's interesting, Tracy. Congratulations. Yes.
So Emma, whenever you're ready, there we go.
Okay, I'll start. So obviously the topic, and I agree with Robin. If we can go back to the topic, I think it's probably attracted a lot of people because it's very real for a lot of people. So if you can just take a moment before we even start to think about the wording of it. The loss and grief of mental illness and moving forward. So this presentation will talk a lot about the loss and grief, but the moving forward, it's different, but you get to move forward. I think that's equally important. So next slide. So I'll start off with what is grief. And there's millions of definitions out there, but it's the emotional suffering you feel when someone or something is taken away from you. There is an array of emotions like anger, sadness, guilt, anxiety, yearning, denial, shock, a million more. But it's this, flood of an emotional experience. Now, it also impacts our physical health, cognitive, and spiritual aspects of the person. But tonight we'll be talking particularly about the emotional suffering. And it's a very deep personal experience. So everybody has a different experience with grief. And then people often say, well, what's the difference with grief and mourning? And mourning will come up a little bit in the talk later too. So mourning is the process one goes through leading to an adaptation of the loss. So again, the grief is my emotional experience to the loss. And then the mourning is how I'm going to, if you like, plod through it. And in more recent work, there's tasks to mourning. And I'll just, so that there's the, task number one is accept the reality of the loss. Because usually, certainly when it's a death, there's a big, shock and disbelief. The task 2 is the process the pain of grief, because like I said above, there's tremendous pain that go, you know, a whole array of emotions, plus the physical, spiritual, and cognitive that goes with it. Task 3 is adjust to a world without the deceased. And now in our case, the person is not deceased. And then task number 4, find connection with the deceased, or in our case, again, we'll be looking at it a little bit different, while embarking on a new life. So there's actually, there's the grieving process, and then also there's the mourning. So next slide.
I'm done. Sorry. For some reason,
That's okay.
for some reason, it's not going.
Okay, there you go. Huh.
Okay. So then there's different types of grief, and I've just mentioned a few here, and the ones in red are the ones I'll be particularly focusing in on. But there's anticipatory grief, and that's for an impending loss. So say if somebody was dying, like an example of a terminal illness, and there's waves of hopes and disappointments, but you kind of know what's going to happen. Then there's disenfranchised grief, and that was a term coined by a Dr. Kenneth Doka, and the definition he uses is a loss that is not openly acknowledged, socially validated, or publicly mourned. It's like invisible losses, suicide, drug overdose, abortion, or mental illness. Again, there's lots of other examples. And tonight, obviously, we're talking about mental illness. So basically, a loss that is not openly acknowledged. That's what I hear from the parents I work with, the families. They'll say it's not openly acknowledged. Then there's complicated grief, and that's a persistent and pervasive sadness that interferes with the ability to function, and it usually evolves into a depression or anxiety, but it gets complicated. Grief is a normal, natural response, but it gets complicated if you're 2 and 3 years later and you're not able to function. That's, where it gets complicated. And then the other the other form of grief, ambiguous loss, and again, this comes into our topic tonight. That was a term coined by Dr. Pauline Boss, and where the person is either physically present but emotionally absent. So we see a lot of that when we're talking about mental illness, or emotionally present but physically absent, like a missing person. And obviously, what's going on in the world today, the war in Israel, obviously what those families, you can see them if you've been watching any of the, they're so emotionally, but they're physically their loved one is missing. So the disenfranchised grief, it's not, as I said, openly acknowledged or, socially validated. And then the ambiguous loss comes into with mental illness, because, like I said, a person might be physically present. However, their behaviors or their emotions, or a lot of people will say, I feel they're kind of stuck in there somewhere, but I can't seem to access them. Next slide. So I just, wanted to kind of have a little visual for you all. And I said, although not always named or resolved, grief is central to the experience of mental illness, both the lived experience and for loved one. So again, we've got the disenfranchised loss, the ambiguous loss, and then there's secondary losses that come with that too. Next slide. So the secondary losses, and I just got this example, obviously this is related to an actual primary loss of a person who died. But if you can imagine in what we're talking about tonight with mental illness, there's all kinds of losses, loss of, income, identity, loss of dreams for the future, faiths, loss of confidence, financial security, support system. That's a big one that comes up a lot, the loss of support system. And I don't know if you want to just take a second again in your own mind to think about, your either the lived experience of the losses you've experienced, or what families, what you've experienced as a family. And just to think about from your own personal point of view. Next slide. So then I just put them in under functional losses is, like I said, the earnings, the education, work, driving, that comes up a lot with young people in our clinic, social network, medical insurance, relationships, your ability to take care for self, and independence. So there's a lot of functional loss. And often associated with the functional loss, you'll hear about the burden, caregiver burden, and that's heavy with the functional, losses. But there's also identity losses for both the family and the person with the lived experience. And that gets into your, self-image, identity, your self-esteem, ideal self, hopes and dreams, relationship with yourself and the world, spiritual crises, self-efficacy, so there's a lot of identity losses. Next slide. And I just wanted to talk a little bit more about, our self-concept, and we all have it. So again, lived experience, families, all of our, we all have it, self-concept. And that kind of, in our self-concept, it's our self-image, our self-esteem, and our ideal self. So our self-concept is how we see ourselves, our beliefs and opinions about ourselves. So I'll just speak with the families for a second, so a lot of the families will say to me, I don't know, I had a son who I thought was going to, go off to college and have this wonderful, become an attorney or something. And I was involved in his sports, but all of that has changed now. And I don't know how, how I see myself in the parental role now. And then the self-esteem is how we feel about ourselves. And then the ideal self is, who do I want to be? So some things that come into the self-concept is, and again, I've just listed a few, but that sense of inadequacy. A lot of, young people that I work with, they'll say, I'm feeling inadequate now. There's a lot of blame. And when I'm reading these out, this cuts both ways for the person with the lived experience and the family, because there's huge overlap in all of this. So self-blame, viewed as weak, stupid, low IQ, hopeless, case, crazy, powerlessness, a tremendous sense of powerlessness, embarrassment. A lot of people are very embarrassed, a lot of shame, trauma, denial of feelings, wrong to feel this way. Well, I'm not in ICU, or I haven't died, so I need to be grateful here. And then the real personal questions. Who am I now? And both families and the lived experience ask that. How do others see me now? And how do I see myself now? And the bottom one to me is, as a therapist, that's huge in our therapy sessions. How do you see yourself now? Next slide. Again, this, with the self-concept and self-esteem, it's so caught up with the stigma of mental illness. And so again, I cannot, mention one and not the other. So the stigma of mental illness minimizes both acknowledgement of the losses and the community supports typically provided to people affected by less stigma trauma, such as accidents or natural disaster. So again, if I have my daughter ends up in the hospital with appendicitis, people will come and visit her, they'll acknowledge, they'll ask me about it, they'll tell me stories about their own kids, whatever. But when stigma creeps in, as it happens, unfortunately, with mental illness, this cycle starts. So there's a negative perception of mental illness. So it's kind of like, oh gosh, I better not even talk about that. Then because of that, there's the fear of discrimination. Again, will I be discriminated against? And again, how will people see me? Then avoidance of help, a lot of, and I keep referencing young adults. That's the population I work with. Of course, this reference everybody, but my references are from my work. So, avoidance of help. And then untreated mental illness perpetuates stigma. So again, we go around in circles, and that's a big part of the grieving and the loss of mental illness. And as a therapist, again, we have to go there looking at the stigma. And a lot of people on first blush, they'll say, oh, I know there's stigma out there, but that's not me. I don't see, I treat everybody the same. I wouldn't think anything negatively about them. No. But actually it's very, very deep, and it's can be very covert. So we have to kind of talk about it very openly. Next slide. So the loss and grief of mental illness and moving forward. So again, we want to think of what are some of the losses, and what's, why does grief even come into play? What's the difference? So I'm going to talk here for a minute about the lived experience. Okay. So it's very, as I say, it's very, very complex. So how I relate to myself and the world differently as influenced by active symptoms. So first of all, if I'm having certain symptoms, I see myself and the world and my family and my friend, I might see things very differently. So that's going to, influence things. Do not share viewpoint of family or providers may not agree with the diagnosis. So this happens every day in my work, where, the young person on the unit will go, I don't, know, I don't like labels, but I'm not hearing voices, or I'm not paranoid, or I'm not, there's nothing wrong with me. It's all a big mistake that I'm here in a psychiatric unit. So they see it very, very differently to what the families might see them, or even, us as providers. So that's a complication. Grief may only be seen in its component parts. So like I told you, remember, there's an array of, emotion, very strong emotion that can come with it. Anger, frustration, denial, all kinds of things. And sometimes, certainly in our first episode clinic, I see it. Sometimes when a person is, struggling with trying to figure out what's going on, there can be a wide range of emotional experiences. And sometimes people, us included, the mental health provider, we don't stop to think, well, wait a minute, what's it like from their experience? And then further along, now there's a lot going on initially, so the grief would come later, but it gets misdiagnosed as further symptoms of mental illness. So then, it gets pathologized. And we want to be careful with that, because some of it is a very normal, natural reaction to everything they've been through. And in the clinic, I can tell you from, working with people fresh out of the hospital, that usually happens in month 2, 3, 4. It's not in the first, week or two, or because their head is still kind of spinning coming out of the hospital. Then there's more urgent matters. You know, initially, certainly in a hospital setting, there's active symptoms, there's medication adjustments, there's the diagnosis, sometimes there's legal issues, and they all interfere with grief reaction later on. You know, they all kind of get in the way. So that's another complication. And then also what's kind of confusing is there's glimpses of old self. So a lot of people say, yeah, I kind of feel like my old self again. And they're returned back to their baseline. So they might go back to a job or go back to school or something. And they think you're thinking in the moment you can move on. So therefore, there's no acknowledgement of what happened. Unfortunately, though, sometimes, not all the time, but sometimes the episodes can come back again pretty quickly. So you're back to square one again. So that's very confusing. So it's hard to grieve something that I'm not quite convinced is going on anyway. And then I haven't got this in my notes, but I just wanted to talk about, very quickly. I was reading after I had done my slides, but they were talking about high expectations and opportunity. So again, when a person had the lived experience, you have these expectations of going back to work or playing on the sports team or whatever, I'm going to get married, whatever is your plans in life. And you go back, with great gusto, but sometimes the expectations can stay very high in your head. But the reality of the opportunities the opportunity is not there as much as you thought. So certainly for work or going back to school. And that's because of the functional impairments. It's not, you try to go back to work, or you might try to go back to school very soon after an episode, but it doesn't kind of go very well. And a lot of people really struggle with that. So that's a huge disappointment when they realize, yeah, I still have all these dreams and hopes and expectations, but I may fall short from if you like, a functional perspective, particularly if there's still, active symptoms, or you're trying to get your medication sorted out or whatever. And often they talk about their lost potential at this point. They're like, I'm trying to go back, saying, to school, and it's not working out for me right now. And I have this, I've lost my potential. And that's where then there's a correlation with depression and afterwards for when, and particularly they say from higher socioeconomic group. So if the home has, everybody is, say, educated and has careers, and the expectation is that, yes, you'd go on and, go to law school or whatever. And when that doesn't happen, the disappointment for both the families and the person with the lived experience, and they say there's higher levels of depression than, say, if the expectations are not quite as high. So, again, it's complex, because we all want to have a certain degree of expectations, and we have a sense of our ideal self. However, sometimes we have to be careful with it. Next slide. So for the family complexities, but again, like I said, there's some overlap here. So the grief can often get delayed. And sometimes I was reading that the grief, like a death of a loved one, the grief is very instant, it comes pretty quickly. However, when it comes to mental illness, it can be 2 or 3 years of a delay. And you might go, well, why is that? Well, what happens is, it's delayed initially because naturally families are focused on diagnosis, prognosis, different treatment approaches, different research, so your mind, you're very busy at that time. Grief is subtle and disguised in the intense emotions, especially the anger, blame, guilt, related to the families will have this deep sense of hopelessness, powerlessness, helplessness. They're like, oh my God, what, we need to do something. What can I do? So there's tremendous, and often that, like I say, you're so busy in the initial period anyway, that your head is kind of spinning. And then there's, all families, naturally, I have a daughter, a 23-year-old myself. We all have expectations, going back to that previous slide about expectations and opportunities. And so the expectation starts to change. The image, the image of my child starts to change, or my loved one. And then there's changes to the family system, whether we like it or not. And then there's the cyclic nature of the illness. It's very confusing, just like with the lived experience, as glimpses of past life and now present life. So hold on to that. It'll come up later, but glimpses of the past life is still actually very important in the grieving process, because it's still the same person. But obviously circumstances are different now. There's we have to look at the present life. Sometimes it can take years to understand the changes that will likely occur in the family. So it's very difficult to kind of get your head around it, because we know with the cyclic nature of mental illness, sometimes you might have a couple of years, 2, 3, 5 years of, and then it might come back again. And you'll see that particularly with the bipolar affective disorder. I've seen people where they've been, very stable for years, and then for whatever, different reasons, they may have an episode, like a depressed episode or a manic episode. The other complexity with families is the siblings' reaction. So not alone are your own head is spinning about what's going on with your loved one, but now you also have, the children and then the siblings among themselves. So there's a lot of survivor's guilt, fear for their own mental health that comes up all the time. They'll say, well, is this going to happen to me? And they're very sensitive about the burden, the family burden of the mental illness, particularly if it's a crisis. Another complexity that comes in, and again, it can be very subtle, but it starts to come in, is the substance abuse. It might have been there beforehand, but certainly I've seen a lot of that in my clinical work, where again, because of the distress, all of the above, a person will turn to substances because it's too painful, so they just want to numb themselves out. And then often for families is a family psychiatric history. So if they have witnessed, and I with my work with the families, a lot of families will say, I witnessed my grandma or my uncle or my granddad or whatever, and I saw the poor outcomes. So they're usually talking 10, 20, 30 years ago. So naturally, when it hits, if it's their, a child, all of those, traumatic events and memories and outcomes completely blur the picture. So they're like, again, it really exaggerated that sense of helplessness, like, oh my God, they're never going to get better. And I don't know if some of them are in the audience tonight, but with my families, I'll always remind them that this is 2023, that there's been tremendous progress, like in all medicine, but there's been tremendous progress in mental health treatments. Next slide. Yeah. Oh yeah, I just, this is a little quote I got from one of the papers I was reading. I have my references at the end of the slides, but I liked this one. All young people are conscious of their parents' ambitions for their future. When this future is taken hostage by mental illness, the young person is likely to be aware of the loss of this future, not only for themselves, but also for their parents. So you can see again the overlap of the lived experience and the family. It's all one, really. It's just one system, it's a family system. Such losses may include personal achievements, career, and other cultural milestones, independence, and children or grandchildren, and so on. The effect of the illness itself, as well as medication, can render invisible the feelings of the person experiencing mental health crises. So that just kind of gives you a little glimpse of, often families think, well, the person is oblivious or they don't care. And that's not actually accurate. They are very, the person with the lived experience is often very, very sensitive about, how this is impacting their loved ones. So, yes, next slide. Right. The family, the high expressed emotion. So this comes up a lot, and I like to just bring it in that it gets in the way with the grieving process too. It can kind of, it kind of blurs the picture a little bit. So with when we work with families, it's a construct called high expressed emotion. Now, again, I'm going to be very clear. No blame, happens lots and lots of people. However, some families are very hostile. It's because they're so upset, and like in the previous, they're so helpless and powerless, and they're so emotionally distraught that they don't know how to manage their own anger. And so it comes out. Just like, if we're all having a bad day, sometimes we lash out at people. So the hostility, it's really to do with themselves, but the hostility can come out in the family, the family system, and certainly say with a loved one that has a lived experience. So again, I'm just going to use our clinic as an example. So if the young son continues to say smoke, weed, and he won't take his medications, and he won't tell them where he's going in the evening, you can, obviously the families can get very upset, and there's a lot of hostility. They're lashing out at the young person. And of course, that does not help, the family, or it doesn't help the person. Another big one in high expressed emotion is the emotional over-involvement. And that's where, again, it's understandable, because when you maybe get this diagnosis that your young 22-year-old has a diagnosis of, say, schizophrenia, you overreact because, again, you're so distressed. So that's when people are reactive. Sometimes they're overly protective. They're overly identify with the person. They're like, oh, I can just imagine, whatever. And there's a lot of almost self-sacrifice. And again, it's understandable, but when that's going in the direction of the person, the lived experience, sometimes they find that very, very stressful. And I'll see it a lot, and I always joke with my the families that I'm working with about, particularly the moms and the grandmas with the young sons. And they're there, and they might be, brushing their teeth, or they're cleaning, spit off their face, or they're doing something, they're fussing over them. And for the young, a lot of the young male, they're like, oh my God, just give me some space. It's too, it's too much. And again, that speaks a lot of their own, you know, the parents' distress. And then another one is the critical comments. And that's where, again, because of the distress of the parent, but you're looking at this, again, we use the example of a young person, and you're like, they're lazy. They don't care anymore. They're, you know, they're not trying. You know, I'm tired dealing with this. This is a bunch of, you know, crap. You know, so their comments and their tone of their voice is very, very critical. Again, it's because you're upset and you're grieving, probably, certainly if this has been going on for a couple of years. But again, you can't really say it out loud, and no, it's not validated socially. So it comes out in other ways. And so the high expressed emotion, we see a lot of that in our work. And as the years go on, certainly if there's been several episodes, you know, with in our clinic, sometimes there's a lot of hospitalizations initially. There could be 5, 10, 15, and families get wore out. They're, you know, they're worn down, and then emotionally, they're very distressed, and it really can interfere. Again, now it's different than grief, but it can become part of it. So I like to, you know, mention that. Yeah. And going back to, I just wanted to make one other comment I saw here. Yes. I want to say here that when both when the families are grieving this lot, the grief is similar in magnitude to a loved one's death. I'm going to repeat that. It's actually similar in the magnitude to a loved one's death. However, initially, because of, remember I said, you know, you're trying to get the diagnosis, the symptoms, everybody is kind of, there's a lot of confusion and disbelief. It doesn't happen on the front end, but, you know, a lot of the literature is saying, you know, 2-3 years, because it can take up to 2 years to get a proper diagnosis. 2-3 years later, boy, oh boy, does it come out. And then when you don't know what it is, it's very, very confusing for everybody. So, and there's been a lot of studies apparently done on that, where they'll talk about the grief is higher a couple of years later compared to, say, if somebody died. Next slide. The other thing that complicates the grief is, and again, I could do a whole lecture on attachment styles here, but attachment, it's, when we're talking about grief, really it's about, you know, how the bonds that we have for the person that we have loved, either in death or if mental illness has kind of really changed their personality and their, you know, reactions, if you like. So most of us have secure attachments. We have a healthy relationship with our primary caregiver. Now, this goes both ways too. I've seen it where I've worked with people where it's their parent who has the mental illness and maybe having the episode, or it might be the parents who their, you know, young adult is having their, you know, first episode. But there's different kinds of attachment, of how we bond to people. As I said, there's a lot of theories on it. Basically, attachment starts from our when we're our infant to our primary caregiver, which is usually the mom, or it can be the father too. But a lot of the studies are done with the mother and their children, how they bond. Adult attachment is a little bit different. However, we can kind of go back to our childhoods. So if you have an ambivalent attachment, usually, so again, we use the example of, say, your loved one is a young adult or something. If the attachment between the family and the loved one is ambivalent, usually there's a lot of anxiety and there's a lot of kind of mixed feelings. There's that kind of push-pull, push-pull, push-pull. Then for some other people, it's an avoidant attachment style. So they never really were dependent on their parents or particularly close. And they tend to be very self-reliant people. They don't really rely on anybody. So say if they're with their diagnosis, I've got some young men and women, and where they kind of want to take care of it themselves, and their loved one might be reaching out, they're wanting a closeness, but there's this avoidant attachment that happened years and years ago. And then of course there's a disorganized attachment, and that's where there's a lot of confusion, a lot of kind of push pull with that one. And they tend to be with the disorganized attachment style, there tends to be more aggression and antisocial behavior. But certainly we have to ask ourselves, like when both the lived experience and then the families, you have to kind of get very real in your grieving about the how attached was I to this loved one before ever the illness happened, and how did our kind of dynamic play out. And again, it's not that it's a bad thing, they're just, but we have to be aware of attachment styles, because they do come into of how we grieve later on. So yeah, next slide, please. Yeah. Another aspect that I really want to mention, because it's very important, is both for the families and for the person with the lived experience. Because, and I've just mentioned just some of the complexities, you can easily get to the point where you feel pretty desperate and pretty shattered, and you're thinking nobody really is understanding, nobody is getting this. So suicidal ideation, whether it's active or passive, always for us as in the mental health profession, we always ask about that, and we always want to be checking it out. And the good news is now they have, that's why the 988 number, it's for Suicide and Crisis Lifeline. So even if you don't want to talk to anybody that this line is very good. And what I like about, they also have texting, because for the younger population, they tend to text more than they'll call. But just knowing, again, it's not unusual. Often people go, oh my God, I better not say that I'm having these thoughts, or you guys will throw me in a hospital, or, not at all. These are situations that if you can talk to, now it's better if it's a professional, I'll be honest, because we deal with it every day. However, but the crisis lines, they're all well trained, and they definitely will help you out. But it's not, again, going back to the disenfranchised loss, people will say, well, I can't say that I'm feeling this, desperate enough that I'm having thoughts to hurt myself, because look, my son or daughter, they're still alive. There's not a problem. There's a war going on, for God's sake. But that's not how this works, because like we said, again, grieving, it's a very, very deep personal experience. Next slide. Okay. How am I doing for time? Yeah, I'm okay with time. So,
You're okay.
Yes. So a few things to think about as you're moving forward, on this journey, both for the loved one and the family. So recognize how grief shows up in your life. So basically, just like a very fundamental question is that and that's in therapy, I do a lot of this in my work with the young adults, is kind of what have you lost along the way? How is life different? What exactly happened? And I get them to compare their kind of, previous life to the life they have now. Now, thankfully, I can speak for in the work that we do in the First Episode Clinic. thankfully, most of our young people, if they really want to go back to college or get a job or train in something, that absolutely happens. And I know, again, going back to the stigma, people go, schizophrenia or schizoaffective disorder or a bipolar affective disorder. Oh no, you're going to be disabled for the rest of your life. And that's not accurate. So it's important to ask yourself, how does the grief show up? Recognizing the symptoms of grief. So I would recommend to anybody to read up a little bit about it. There's a lot of good podcasts out there on grief. There's a lot of, support groups like the NAMI support groups. There's a lot of place where you can learn about grief. And recognizing grief works on its own clock. It can vary in impact. So again, often people will think in terms of, well, maybe it's a year, or maybe it's 2 years, or, maybe it's 6 months. And grieving, there is no end, actually. The acuity of it goes, and the rawness over time, but the grieving itself and the loved one's place in your heart will never leave you. So again, thrown out, there is no time factor here. A grief lens may enable this to be seen as a vulnerable time with potential for personal growth. If losses are acknowledged, new possibilities supported, and inevitable changes are integrated. So that's basically what happens in, say, the work that we do in our clinic every day, where, and certainly I've seen some of these young men and women now, I've literally worked with them for over a decade. So we know, we acknowledge some of the things that have changed for them. Certainly, I've seen a lot of relationships break up. Unfortunately, I've even seen people handed their divorce papers while they're on the inpatient unit. I hate it, but it happens, so we've seen, so we acknowledge those losses. And then we look at the new possibilities and where they are today and parts of their old life they might want to integrate, things they've learned from their experiences and from the illness and all of that. It's very, very valuable information. And then we, move, there are inevitable changes, just like in all of life. We're always changing. There's always things happening. Crisis comes into all of our lives. And it's how we integrate it, but we're still moving forward. And I always encourage getting support. Some people are not as, what do we say, eager to seek professional support. But thankfully, when it comes to mental illness, and NAMI is a great support for them, because they're with regular people and they say, they just feel, a lot of people say they feel more supported in the NAMI community than they do in the mental health community. I hate to hear that. However, going back to our slides about, high expressed emotion and attachment styles and substance abuse and that, I've heard from more than one person in my career where they say, unfortunately, when I was talking to the mental health professionals, they were not supportive, and I felt kind of blamed and judged and, whatever. So that's why I think professional or community. And the losses and the grief needs to be addressed directly and with compassion. And for some sessions I've had with some families where they'll talk a lot, say, about their son or daughter, all of the things that was going on for them. And again, I think that that's great, and we have full sessions on that. However, it is important for the family and for the, lived experience at the same time, of kind of going, okay, how can I integrate this now and move forward, you know, in my life? So next slide. Oh, I just had the little picture of the support, all the, you know, all the hands out. The next slide. Now you can all do a collective groan if you want. People are so tired of self-care. They're like, that's what, but trust me, when we're grieving, like we talked before about, because it's so emotional and physical and spiritual and cognitively, how we think and, you know, problem solve and all of that gets disrupted. It really does. And there's some days are better than others. So taking care of yourself is very important. And, you know, I just found this, you know, but here they talk about, what is it, hobbies and sleep and nutrition. Some people do a gratitude list, your social interaction, your boundaries of basically, you know, the boundary of, if when you're grieving, like I say, because there's so much going on, you may not be able to do as many tasks as you used to. And it's okay to take a time out to say, you know, for now, I need a break, or for now, I don't want to get involved, you know, and you kind of really wrap that kind of blanket psychologically and physically, if you want, around you, where you're taking care of yourself, because there is a lot going on with with grief, and particularly when with mental health, like we said, a lot of people, it's not acknowledged openly. So unless you're the one to kind of bring it up, a lot of people don't want to ask because they're afraid. And yeah, often people will say they feel very isolated in situations like this. So then next slide. And this little graphic I found, and I liked it. It's people think that grief, and you can notice the circle is pretty full, slowly gets smaller with time. In reality, grief stays. So again, your loved one that's struggling with mental health, the person is always there. The person is still there, the same size, but slowly life begins to grow bigger around it. So that's that integration that we're talking about, as in, and I know in the work that we do, you know, with, it doesn't matter the diagnosis, and like often people say the worst diagnosis is schizophrenia, but actually with schizophrenia, with good treatments and good supports, have I seen young men and women move on in their life and complete college and have relationships and travel and whatever. Absolutely. And you know, I can vouch for that. So I just like that little graphic. And yeah, and next slide. I think I just had the references. Yes. I just listened to that, the importance of mourning losses. And that was a nice, you know, it's a short recording. And the next article that came out of Australia, I really enjoyed, and I used some of the quotes from the Jeff Young article. And then in Warden, that's just you know, we use it a lot in our work, grief counseling and grief therapy. But there, if you want to find out more about the tasks of mourning and about complicated grief, or, you know, obviously it's a textbook on grief. And then, as I said, Kenneth Doka is the one that talked about the disenfranchised grief. Grief is a journey, finding your path through loss. And then the Pauline Boss is the woman that came up with the ambiguous loss and the myth of closure. And actually, I was reading, she has more recent work on about COVID and the pandemic and the losses. You know, she thinks obviously in years to come, there's so much unresolved grief, because again, we were all trying to survive and figure it out and look for the cure. and there was tremendous losses and grief that happened in COVID. So, you know, if you wanted to look her up, and there's some interesting interviews from her on this ambiguous loss. So, and
Yeah.
I think next, I think that's I think that's it. Yes, thank you. The end.
Well, and and thank you, Emma. That was, I think, phenomenal. Thank you very much for that. You know, we're gonna open the chat room up. So if you want to, and the other reason we use the chat, guys, is because if you want to ask a question and you don't want to you know, necessarily bring it up to the whole group with by speech. It gives a quiet way to do that, and Don will bring anything forward. Emma, I want to just say thank you. I think that was really, and yes, I see Jessica. You know, I just thought that was really great, and I think you brought something to us that we all acknowledge occurs, but don't know what to do with it a lot of times, or we don't. I think some of what you brought forward was the fact that, you know, what we're seeing in some of the aggravation and some of the you know, over attention and things like that really is part of the process that's going on. It's just we're trying to find a way around it. So I think that's just terrific. Thank you for that. And I'm glad you brought up suicidal ideation. I am so glad, because one of the things, we have a new group we started during the pandemic. It's called Friends Supporting Friends. It meets 3 times a week, 3 times a month online. And on Thursdays, it's on our calendar at namidavidson.org. And what we have found is we've created a safe place for hard conversations. A lot of people, you said it yourself, a lot of people experience this. It doesn't mean you're planning to do it, but your brain's talking about it. And it's so nice to have somebody where you can have an honest conversation about it. And you know, some of our group members know that even in those groups, even with those kind of conversations, there's still a lot of laughter in our groups. You know, we do that in the groups. And then that's a lived experience group, but we also have our caregivers groups, and have just started the Caregivers Cafe in addition to the support group, as a social group. So thank you for bringing that up. I think that's really important.
Robin, may I bring up something that has not been addressed?
You can, Pat, if you would, if you wouldn't mind bringing it up in the chat. That way we'll also have a record of it, so that when we do address it, we can do it that way. Would you mind doing it that way? If not,
Okay.
please do.
Well, I would like to just go ahead and do it.
Go
if you don't
ahead, Pat.
mind.
Go ahead, Pat.
This is for parents who have a child who has a diagnosis of a mental illness, and also have other children. My son was 16 when he was first diagnosed and hospitalized. My daughter was a year younger. Of course, they were both in high school. I got very involved with the startup of NAMI Nashville. I mean, very involved.
Mhm.
And my daughter had the courage to come to me one day and say, well, my kids were both very smart, made wonderful grades, and I did, you know, I thought she was doing okay. But she had the courage to come to me and say, Mom, I know you think I'm doing okay, but sometimes I'm not. And it hit me like a ton of bricks. I did not realize how much I was ignoring her. And so I started volunteering, being a chaperone for her band. She was a flag in the high school band and all, and giving her more attention. So don't forget your other children when you have a mental illness in the family. So it's so important. They need some caregiving too.
Pat, I can't thank you enough. I was that other child. And I cannot thank you enough for saying that. My mother told me even years later, she goes, I didn't worry about you. You were okay. Folks, nobody's okay in this situation. Thank you so much for bringing that up, Pat. None of us are. And that's why it's important that, you know, you get your, you know, everybody. I'm a great proponent of therapy. I ended up getting mine much later in life. but just to deal with those kind of things. So you are worthy of support. No matter what side of the coin you're living on, we're all affected by this. So don't,
Absolutely.
reach out and get that support for yourself. You're worth it, every one of you. And by doing this, I've said this today to some folks in a conversation I was having, is that, the prickliest, the best gifts can come in the prickliest packages. And one of the quotes I heard was, a smooth sea does not make a skilled sailor. We learn about life and we develop in life when we're given challenges. We all know on this education night tonight that the challenges that we are given are vast when it comes to this stuff. Whether you're the guy dealing with it firsthand, or your loved one, or like some of us, you're a two-hatter. You do a little bit of both. So, Emma, I really want to thank you for putting this together for us tonight. I think it's quite valuable, and those folks that'll be listening to it later, I think they're going to get a good presentation, a good earful of good information. So, as once again, I want to thank our Vanderbilt folks for coming forth and sharing with us their knowledge, their skills, their experience. Um, do come to NAMI if Vanderbilt is, not in your purview as far as being able to seek help or getting help there. They do have programs. Tracy, if somebody does have an urgent concern, what is a good way for them to reach out?
So, you mentioned the crisis numbers. The crisis is an option always. And then we have a walk-in psychiatric assessment service at our hospital Monday through Friday till 11 and Saturday and Sunday till 7. And after that, folks can seek help through local emergency rooms as well.
Thank you. And in
Yeah.
addition to the local emergency room, if you can, quite frankly, if you can avoid the service there at Vanderbilt is great. So that is terrific. And if there's not a medical condition, we encourage you to go to the crisis treatment center over at the 24-hour walk-in crisis treatment center over at the Mental Health Cooperative, because either of these places, both these places are 24 hours and they specialize in helping people with a mental health condition. So if that's possible, if you have to, do an ER, but if you can avoid it, go to one of these two places. There'll be less anxiety and less overload, sensory overload, because everything else that is going on. Certainly, folks, when you do have somebody that is, if there is a physical condition going on, if you've had an attempt, if there are other things going on, that is a medical emergency, you will call 911 and you will get the help that you need that way. But I appreciate Tracy for bringing up, your services there. They're great services. Emma for what she has shared, especially with 988.